Good morning, friends. Today we have two guest speakers, Dr. Ramesh B. from Madurai and Professor Claire Harrison from London. This webinar is brought to you by Mumbai Hematology Group. It is supported by Novartis, Unipath, Lucien, Natco, and Nirvin. It's managed by Perfect Square. I'm thankful to all our sponsors, event management team, and the executive committee of the Mumbai Hematology Group. Our chief guest for the day is Dr. Shyam Agrawal from Bhopal. Guest speakers, as I mentioned, Dr. Ramesh and Dr. Harrison. I'm grateful to all of you, the discussants, who have joined us to have a very active discussion after both of these lectures. I also thank the participants for sparing their Sunday morning, afternoon, or evening. Next weekend, Saturday, 25th October at 7 p.m. IST, Dr. Kunal Goyal from Mumbai will be speaking on what's changing about the treatment of newly diagnosed myeloma in 2025. And this will be followed by Dr. Akshay's talk on MRD assessment in plasma cell myeloma by flow cytometry. Next Sunday, we have Dr. Vishal Jaikar from London giving us a flavor of what happened in the field of hematology and was discussed and hot in EHA 2025 and Lugano lymphoma meeting in 2025. Some of the discussants, their names are displayed here alphabetically, and there are many more who will be joining us. These are a few more. Dr. Ramesh does not require an introduction. He has been always with us for the last 5 years, right from the days of pandemic when he was doing his DM. To complete the formalities, he is consultant and head Department of Hematology and Bone Marrow Transplantation at Villamal Medical College and Hospital, Madurai. He did his MBBS and MD from the prestigious Madras Medical College. He was university topper and he had a gold medal in MD pathology. Subsequently pursued his DRNB in clinical hematology from Sir Gangaram Hospital, Delhi. After this, he worked as a consultant hematologist and transplant physician at Meenakshi Mission Hospital, Madurai. He started the Department of Clinical Hematology and Bone Marrow Transplantation at Villamal Medical College Hospital, Madurai. He is the first one to do a haplo transplant amongst the medical college hospitals in South Tamil Nadu. His awards and recognition include Best Outgoing Student Gold Medalist in MD Pathology from MMC 2019, Commendable and Best Thesis Award from National Board of Examinations NBE 2022 for his work on acute myeloid leukemia. Winner of multiple quiz conducted at national conferences in hematology by MHG, DHG, and Image. He was one amongst the mentees in European Hematology Association Masterclass 24-25 and involved in active discussions. Today, he will be speaking to us on mutations and MRD-based decisions for managing AML. But before he does that, let me introduce our special guest who is going to inaugurate our webinar today, and that's none other than Dr. Shyam Agrawal from Bhopal. Well, what can I say about Dr. Shyam? He is like brother to me. He has been always with us for all our academic activities, shining the torch of medical oncology and hemato-oncology in MP. Briefly, he is director of a very prestigious cancer hospital, that is Navodaya at Bhopal, and that is also a research center. Well, way back, he did his MBBS and MD in medicine from Gandhi Medical College, Bhopal. He was awarded Dr. Karp Memorial Gold Medal and Certificate of Merit for all-round best student. He did his DM in medical oncology from the prestigious Cancer Institute, Adyar, Chennai in 1992. That is 35 years ago. He enjoys the reputation of being the first DM medical oncologist of MP and Chhattisgarh. He has founded various important societies in that part of the country: Bhopal Hematology Society, Bhopal Oncology Society, Bhopal Cancer Seva Samiti, which works for the cancer survivors, and Cancer Research Association of Bhopal. He's a member of ASH, ESMO, and got precentorship twice. American Society of Clinical Oncology, ESCO, Mumbai Hematology, MHG, ISMPO, ISHBT, and API. More importantly, he is a member of the advisory committee of the Supreme Court of India for the MIC gas victims. Today, he is going to inaugurate our webinar and also give some very important words of wisdom for all of us, especially for the students. Well, I stop here and request Dr. Shyam to give us the words.
Yeah, good morning, and thank you very much for kind words, Dr. M.B. Agarwal, sir. It is really a privilege for me. Good morning to all my distinguished faculty, organizers, and my dear colleagues and students. I feel especially honored and privileged to be here today to inaugurate this very important webinar where Dr. Ramesh Balasubramaniam and Dr. Claire Harrison from UK will share their knowledge and experiences. I extend my sincere gratitude to the organizers for this kind invitation. As we all know, this webinar is being organized under the banner of Mumbai Hematology Group, a name which is synonymous with academic rigor and clinical excellence, not only in India, but across the globe too. Central to this transformative journey of education and academics is the figure whose name is synonymous with dedication, mentorship, and excellence, and that is none other than Dr. M.B. Agarwal, sir. The growth of hematology as a specialty in our country owes much to the vision and tireless efforts of leaders like Dr. M.B. Agarwal. The Dr. Agarwal's contribution to hematology education are nothing short of monumental. He has dedicated his life to teaching, nurturing countless young doctors, and creating a robust educational platform that is Mumbai Hematology Group. He has truly uplifted hematology education, building a legacy of knowledge that will continue to benefit generation of patients and practitioners. I wholeheartedly praise his and Mumbai Hematology Group's relentless efforts. We are watching every week very, very important and legend who are speaking about the subject, which was not there when we were the students. To the young doctors joining us today, the future of hematology lies in your curiosity, compassion, and commitment. Hematology is among the most intellectually stimulating field in the medicine. It beautifully integrates laboratory research, clinical reasoning, and continuous innovation. Each patient encounter gives you an opportunity to transform despair into hope and uncertainty into healing. Hematology, as one may see it as a niche, but I see it as one of the most dynamic, rapidly evolving, and essential fields in the modern medicine, as artificial intelligence is also coming in a big way to sky high its progress. Hematology, as I observed, is not only the study of blood disorders, but it is the ultimate convergence of clinical, critical care, and basic sciences. There are rapid breakthroughs in genomics, molecular biology, and cellular therapies are being applied to the patient care at a faster pace. You get to be in a cutting edge of science, using targeted therapies, immunotherapies, and revolutionary treatment like CAR T cell therapy to offer life saving hopes to patients with previously incurable diseases. You are working with blood and bone marrow samples like being a detective, where subtle cellular changes and genetic markers unlock the mystery of the disease. This challenge is intellectually stimulating, and it requires a sharp and highly analytical mind. Choosing hematology means choosing a future secure in its relevance and in opportunities for research specialization and clinical practice. So, as we commence this excellent webinar today, let what the expertise share today be more than just an information. Let it be an inspiration. Be curious about the seemingly small details in a peripheral smear. Be courageous in embracing complex science, and be compassionate in the face of serious illness. The torch of knowledge, so excellently and brilliantly carried by the Mumbai Hematology Group and Dr. M.B. Agarwal sir, is now being passed to you. Take it up with pride, dedication, and the commitment to the excellence. The future of hematology and lives of countless patients rest in your hands. I wish you all a highly academic and enlightening webinar. Thank you very much, and I formally declare this webinar open. Thank you very much, sir.
Thank you, Shyam. That was a beautiful speech, so beautifully worded and
Sir,
full of messages. I'm so grateful.
thank you. So kind of you for inviting, sir.
Uh, some of the best of the speeches we have been putting up at the website of MHG.
Yes,
If you help us in putting up your speech, it will be very inspiring to generations to come because it will lie there for decades.
thank
So
you very much.
please do that for us. It was very beautiful speech today.
Thank you very much.
And now let us listen to my pet student, Dr. Ramesh. He is a genius, and all of you will benefit from his presentation today. And in turn, your patients will benefit because more will get cured by the approach that he will be telling you. Ramesh, over to you.
Uh, Thank you, Agrawal sir, for the very kind words. I should thank COVID first, actually, because because of COVID only, we started getting into the MHG webinars, and I have been your student since then. So I'm very deeply honored by your invite, sir. Thank you so much. Let us go into the topic. So the topic for today is molecular MRD based treatment decision in AML. AML, as we all know, this is a very heterogeneous disease spectrum. So you have a lot of mutations, the commonest of which is the NPM1 mutations. And of course, we have other recurrent cytogenetic abnormalities, translocation 821, inversion 16, and so on. And you also do have numerous spliceosome mutations and MDS associated mutations and numerous other signaling molecule mutations. So how to put it into and how to categorize this is how do you this is a overview of the molecular aberrations in AML. First, we have the chimeric gene fusions, which include RUNX1, RUNX1T1, that is 821 translocation, and core binding factor beta, MOH11, that is inversion 16, and PML RARA, of course. And you have insertions and deletions indels, which include NPM1 and FLT3-ITD. And there are single nucleotide variants like TP53 and KRAS mutations. And there is increased gene expression levels like WT1. So, for any malignancy for that matter, especially for AML, there is some founding clone, and there are numerous other subclonal events which are happening within the clone, and that can stay following the treatment, during treatment or following the treatment, that can be resistant or that can be latent, and later on they can show up as a relapse. So we should be very clear enough in knowing and and which clone to follow and which mutation to be followed, so that the patient is deemed as MRD negative, and not to mislabel a patient as MRD negative. So which mutations are to be followed, which are the subclonal events, we should be aware of it. So only then we will be able to know which mutations to chase for and which one not to follow. So this lecture, I want to highlight on the techniques of MRD and which sample to use for MRD, whether it's bone marrow or blood sample, and what time points it is favored, and how does it help in making a clinical decision and for improving the results of the patient. So these are the broad classification by what are the techniques by which MRD is being tested. For the first, we are all aware is the multiparametric flow cytometry. This is by leukemia-associated immunophenotyping or different from normal techniques. So the sensitivity of this technique is somewhere around 1 in 10,000 cells, and and it is advantageous that the rapid turnaround time, and it's like highly standardized also. But AML, as we all know, this disease is one which is moving away from chemotherapy towards a targeted therapy era. So how this is has become possible is by identification of numerous mutations, and which mutations these mutations and molecular targets can be followed up, so that we can detect an early relapse, that impending relapse can be detected very earlier, so that it helps in intervening at earlier time points before a full-blown relapse occur in the patient. So by this, for this we have NGS-based molecular testing or MRD testing, or by RT-PCR based, that is quantitative PCR. So quantitative PCR, like how we follow up the patients in of our patients of CML. We similarly, there is like for the fusion transcripts, there are housekeeping genes, and and the response is assessed as how many percentage log reduction is there compared to the baseline, and also with that of the housekeeping gene. So for that, that is applicable for NPM1 mutation and other fusion transcripts like translocation 821, inversion 16, and KMT2 rearrangements also. So the tissue, the sample which can be used is either peripheral blood or bone marrow can be used. Sensitivity is close to about 1 in 1 million. It is very highly sensitive, but it's the standardization is the main issue, especially NGS technique is concerned. NGS is still more advanced than compared to RT-PCR based one, and this result is expressed in terms of a variable allele frequency, that is VAF. So what is VAF is the at a particular gene locus, what are the variants present in relative to that of the total number of reads, that is expressed as a VAF. So for this, the targets include the NPM1 mutation and FLT3-ITD mutation. So the problem with it is the high cost, and the standardization is still more needs to be done. Coming to the sample, you can either use a peripheral blood or bone marrow. Obviously, the bone marrow is 1 log higher sensitive when compared to the peripheral blood. What is the ELN 2021 MRD guidelines? They say you can use both the samples at the diagnostic time point, at the initial, and the log reduction can be tested for at the subsequent time points. And peripheral blood sample is the one preferred post-induction in NPM1 mutated and core binding factor. And later on, the subsequent samples can be either a bone marrow or a peripheral blood, but the time point will be time durations of follow-up will be different, that we'll discuss in the subsequent slides. So what are to be considered while testing the molecular MRD by NGS? So the first is the CHIP mutations, that is DTA mutations, DNMT3A, TET2, and ASXL1. These three mutations, these are age-related clonal hematopoiesis mutations, and this detection of these mutations following the treatment doesn't mean the patient has the MRD positivity, because these are age-related mutations. This can be not related to the founding clone, or not even the disease clone it can be. So these mutations should not be used for a molecular MRD testing. And next is the germline mutations like SEPA and DDX41, and these are also will not clear away with the treatment. And next is the signaling pathway mutations like FLT3-ITD or RAS. All these can be subclonal events. So these, when they become negative, it doesn't mean that the other clones of the disease can is completely negative, and we may falsely mislabel the patient as MRD negative. And if a patient is on targeted therapy, the molecule other than the which you're targeting has to be followed up. So this is to be kept in mind. So what is MRD positivity by NGS? So any VAF more than or equal to 0.1% is NGS MRD positive, or any VAF less than 0.1% is MRD low level. If it is not detected, it is MRD negative. Coming to response assessment criteria by ELN 21 based on MRD, we have four response categories. First is a complete remission with MRD negativity, and next is complete remission with MRD positive, or complete remission with MRD low level detected and MRD relapse. So MRD negative CR is the name implies complete remission is bone marrow blast less than 5%, and MRD is negative by any of the techniques of flow or RT-PCR based NGS based molecular technique, or MRD positive CRS, any of this technique by MRD is positive with the morphological complete remission, or MRD low level is either peripheral blood or a bone marrow MRD by quantitative PCR for NPM less than 2%, or by NGS technique less than 0.1% VAP should be considered as a MRD low level positivity. So MRD relapse we'll discuss the subsequent slides. So at what time points in what sample? So, but for NPM1, MRD molecular technique follow-up is approved for mutations of NPM1 and core binding factor AML and acute promyelocytic leukemia. You can use any of the methods, quantitative PCR or NGS based. At diagnosis, preferred is both bone marrow and peripheral blood. And at the end of 2 cycles, next when you're going to assess this, at the end of 2 cycles, but that with the preferably with the peripheral blood. And at the end of treatment, you're going to follow up the patient for a couple of years. For 2 years, you're going to follow up. If you're going to use bone marrow, should be done every 3 monthly, or if you're using a peripheral blood, it is every 4 to 6 weeks. Similarly, for the high risk APML patients, whereas for low risk APML patients, you can just stop doing a bone marrow MRD follow up if end of treatment is MRD negative. If end of treatment MRD is negative by molecular technique for low risk APML, you can stop monitoring in such patients. So when do you call this MRD relapse? So NPM1 mutation, MRD more than 2% by RT-PCR, or a log reduction less than 3 to 4 log reduction is MRD relapse. Similarly, for core binding factor leukemia or AML also, less than 3 to 4 log reduction is MRD relapse. Or APML, at any point it is detectable, it means it is MRD relapse. So you have diagnosed the disease, you have diagnosed the AML, and you're inducing the patient, and a patient is a standard risk. Say it is NPM1 or it's inversion 60821, so a standard risk. So it's going to induce the patient, followed by you're consolidating the patient, and the patient is in complete remission. And if the outcomes can be, the patient can be MRD negative, or the MRD low level can be present, or MRD persistent or MRD positive. So later on, you are monitoring the patient subsequently, as we have discussed previously. So the patient of MRD negative can become MRD positive at any point of time, that is MRD re-emergence, or the patient low level MRD, which is being present at the end of consolidation, can increase in the log, increase can be there, that is MRD progression. So both these you call it as MRD relapse. Or MRD can be persistent following consolidation, that is MRD persistent. So all these you are calling it as MRD failure, and these patients can be subjected to preemptive therapy. So we do not give a preemptive therapy in all the patients. What you should consider numerous factors in choosing your patient for a preemptive therapy. So consider not only the chronological age of the patient, also this biological age, and what all the comorbidities the patient is having, and what is their performance status, and what all the medications the patient is taking, what is the polypharmacy, and what are the drug interactions, what is previous treatment the patient has received, any either intense or less intense therapy, all and what is the patient's preference, and what are you aiming for. The patient is to be so all these factors have to be taken into consideration before taking up the patient for a preemptive therapy. So the patient can go in either way. You are going to treat the patient the intense or a less intense therapy. Say you are going to choose the patient for an intensive therapy, and the patients are not transplanted because they are falling in the standard risk. So you can intensify the consolidation, or after following consolidation, if there is MRD relapse occurs, you can either give a salvage kind of salvage therapy even before the full blown relapse occurs. By using a targeted molecules, HMA-VEN or low dose Aracey-VEN, and you can bridge the patient to a transplant. Similarly, following transplant, if the MRD can be followed following transplants. So for before the there is a before there is a occurrence of mixed chimerism, or you can pick up a mild increase in the MRD, mild positivity of the MRD, and then you can consider the patient for a early tapering of immunosuppression, or you can use a prophylactic DLI, or preemptive DLI can be used in such patients. Or you can even consider starting the patient on some targeted therapy following transplants. So now we'll move on to each individual mutations. So what is the data, and how does MRD help in designing the treatment of the preemptive treatment in these patients? First, this is NPM1 mutated patients in the AML 17-19 trial. There were around 1300 patients, and the molecular technique used for MRD is either NGS or quantitative PCR based technique. This is a sequential prospective randomized trials of younger patients treated with intense chemotherapy. AML 17 post-induction MRD results were not used to assign a risk group, whereas AML 19 patients with the detectable peripheral blood NPM1 mutation after 2 induction courses, they were considered as high risk, and these patients were subjected to high risk randomization with FLAG-IDA or CPX 351, and they were recommended for transplant in first CR. So coming to MRD positivity and the survival in this study. So as you can clearly see, MRD negative is the red graph. The survival probability, the overall survival is much better than patients who are MRD positive, and is sustained for 5 years. Similarly, the rate of relapse rate is around 60% in patients who are MRD positive, whereas it's only close to 20% patients who are MRD negative. And the univariate analysis shows that high WBC count, all those in red rounds, and high WBC count, WT1 and FLT3-ITD D93A, all these have a high risk of patient being MRD positivity if these are co-occurring with NPM1 mutations. One point I want to stress is you have to take into consideration what are all the other co-occurring mutations other than the one which you're choosing for monitoring. The co-occurring mutations also matter a lot in NPM1, also in 821 and version 16. So here in multivariate analysis, you have the patients achieving the odds of achieving MRD negativity is more if the patient is subjected to FLAG-IDA. So the chance of becoming MRD positivity is more if the patients are having the non-ABD mutations. Among the NPM1, there are the 3 common mutations, A, B, and D. The non-ABD mutations, they have a high risk of being MRD positive. And if there are occurrence of co-occurrence of DNP3A, FLT3-ITD, or WT1, the chances of MRD positivity is higher. Survival rate in these MRD negative patients. So the oral survival is better if the patients are subjected with a FLAG-IDA therapy rather than all these mutations which we have discussed, co-occurring mutations. And the intermediate adverse risk cytogenetics also, if it is occurring along with that, along with the NPM1 mutation, the chance of relapse is more. When we take into consideration FLT3 status in MRD in NPM mutated AML, so FLT3 ITD mutated patients, the survival is slightly lesser when compared to if it is wild type. And MRD negative status could abrogate this negative effect of the FLT3 ITD mutation. That is what is shown here, rather than its MRD positive. But one flaw with this is FLT3 inhibitor was not used upfront in these trials at that point of time. Effect of other mutations here is FLT3-ITD, DNMT3A, WT1. If there are more than 2 of these mutations present along with the NPM1, the survival is way lesser than patients who are all wild-type TOS. The poor survival in patients who are having more than 2 mutations, this could not be abrogated by transplant also. So here comes is there any role of menin inhibitors if we add to this? So that is under study now. So MDS associated mutations doesn't add to the negative effect in these patients of NPM1 mutated in this study. There are no major difference in the oral survival or lapse rate if it is co-occurring with NPM1 mutation. But interesting point is the co-mutation pattern was slightly different. There was IDS2 mutation, TET2 mutations when present in this patient. Maybe IDS2 they'll respond very well to venetoclax. That is the reason maybe they are doing good. And more than 2 MDS mutations, they had a trend towards a poor outcome, though it was not statistically significant. So this sums up. So patients who are having non-ABD mutations and FLT3-ITD mutations, they have high risk of MRD being positive if it is co-occurring in patients of NPM1 mutation, or if the patient is having a type D mutation of NPM or other signaling molecules like KRAS, NRAS, PTP, and 11, the risk of MRD positivity is lesser and the relapse rate is slightly lesser. So moving on to the next trial is Alpha Nod 7 Nod 2 trial. This shows, this is from the French group. They say in this study, more than 4 log reduction is associated with the better overall survival, and the chances of relapse is also, cumulative incidence of relapse is also way lesser. So to transplant or not in patients of NPM, this study addresses that if there is more than 4 log reduction, there is no major benefit in doing a transplant of these patients. Whereas if there is less than 4 log reduction is only there, then if you are going to do the patients of, for transplant, so they're going to benefit. The disease survival becomes lesser and the overall survival improves if you're going to transplant the patient if they're having a less than 4 log reduction. So is there any role of NPM monitoring in less intense treatment? Yes. So this published in last year Blood. So MRD, molecular MRD testing is strongly prognostic in patients of NPM mutated AML receiving a venetoclax-based less intense therapy. The median age group of this population was 72 years. And here you can see the disease category. Secondary and therapy-related AML contributes to close to 20%. It's 1/5 of the patient, they had a very high risk category. So but the response rate were very good. Morphological complete remission was present in 95% of the population. And if we see the MRD negative status by the end of 4 cycles, the overall survival is much better than patients who are not achieving an MRD negativity. And similarly, the event-free survival is also better if they are MRD negative, and if they are MRD negative, the cumulative incidence of relapse is lesser. And this one shows the preemptive treatment for patients. In this study shows a preemptive therapy for treatment for patients who are NPM1 mutated and having a molecular relapse or molecular failure. So these patients are treated with a less venetoclax or less intense chemotherapy if they're having a molecular persistence or molecular relapse. So once they're subjected to this therapy, approximately 70% of the patients, close to 1/3 of the patients, more than 1/3 of the patient, they achieve very good response rates. The response rates becomes response is slightly inferior if there is co-occurrence of FLT3-ITD mutation. The overall survival is also lesser if the patient is having a co-occurrence of FLT3-ITD mutation. Next, moving on to core binding factor leukemia. So the MRD concept in molecular MRD concept in AML, core binding factor leukemias have started in 2006 itself. So this is a core binding factor NOT6 trial, RUNX1 T1 or core binding factor MOH11 transcripts fusion were tested at the end of consultation 1, 2, 3. That is MRD time points 1, 2, 3. There were 2 treatment arms. One treatment arm B, I'll just tell. It's a standard 7+3 induction. Treatment arm A is almost the same medications of cytarabine as well as daunorubicin, but the dosing schedule is slightly different. The patients who had less than 3 log reduction in MRD before the second consolidation, they were transplanted if they were having a full match sibling donor. So this is so as we have highlighted previously also, the co-occurring mutations, they matter a lot. So here the receptor tyrosine kinase mutations, those in the dotted lines are the receptor tyrosine kinase mutation, either KIT or FLT3 mutation. If that is present, the cumulative incidence of relapse is higher, and the relapse-free survival probability is better if there is no receptor tyrosine kinase mutation. And the cumulative incidence of relapse is more if the patients are having a less than 3 log reduction in the in the fusion transcript, and their survival is better if there is more than 3 log reduction. Similarly, the oral survival is also better if there is more than 3 log reduction. So the multivariate analysis for the relapse risk shows only the MRD log reduction more than 3 log is associated with the lesser relapse risk in both 821 and inversion 16. Whereas if we see for overall survival, the multivariate analysis, there is slight difference. In 821 translocation, this MRD reduction more than 3 log holds good, whereas it does not improve the overall survival in patients of inversion 16. This means that the dynamics of molecular MRD and the molecular mutations is different amongst the core binding factor leukemia also. So this trial from China shows they have used allogeneic transplant for the patients of 821 translocated inversion 16 in patients who are not achieving major molecular response by the end of consolidation 2. So the patient's molecular response was tested for the end of induction, consolidation 1 and 2, and subsequently at the end of each consolidation. So the patients of major molecular response is the more than 3 log reduction is considered as a major molecular remission. And if there is patients are not achieving a major molecular response, they're considered as high risk and they're subjected to allogenic transplant. So this is a concert diagram, and the patients who are having the high risk, those are not achieving a more than 3 log reduction. Those patients are high risk, and the cumulative incidence of relapse is more if they're just subjected to chemotherapy rather than transplant. So if you're going to do transplant in such patients, then the disease-free survival is better and overall survival is better. And co-occurrence of KIT mutation, how does it influence is, if there is a co-occurrence of KIT mutations, the cumulative incidence of relapse is higher, and if you're going to transplant such patients, the overall survival and disease-free survival is improves, but it was not statistically significant. Moving to AML MRC 15 trial. So what is the percentage of log reduction? How does it influence their relapse risk and the survival? That is what is shown here. So if there is more than 3 log reductions, the cumulative incidence of relapse is very less. It's only 4% by the end of 5 years. So similarly differs if it is 2 to 3 log reduction. It's around 30% are relapsing by the end of 5 years, and around 40% are relapsing if they're only 1 to 2 log reduction. Similarly, the patients who are alive by the end of 5 years, approximately 85% of the patients, they are alive by the end of 5 years if there is more than 3 log reduction, whereas it's only 50% if there is less than 1 log reduction. For core binding factor beta MOH11, that is inversion 16, if there is only less than 10 copies detected, then the chance of still relapse is around close to 20% by the end of 5 years. Whereas if it's only more than 500 copies are present, it's close to 100% by the end of within a year itself. And the percentage who are surviving is close to 90% if it is more than it's only less than 10 copies are detected by the end of 5 years, or if it's more than 500 copies detected, then it becomes only 50%. So patients who are MRD negative, the relapse risk is much lower, and the incidence of the survival is much better when compared to patients who are MRD positive. That holds similar for inversion 16 also. So there are numerous studies and prospective and retrospective studies highlighting the preemptive treatment for patients of NPM and inversion 16-821. So let us highlight very few trials for discussion. First is the RELISA 2 trial. Patients from 2015 to 18 from Germany of AMDs or AML patients, 166 patients. For these patients, they are monthly monitored with the peripheral blood or a bone marrow MRD for 2 years. So preemptive treatment given was 6 cycles of azacitidine for 7 days, followed by maintenance was continued for an additional of 18 months based on the MRD response. So MRD was tested for NPM mutation and DECNUP214 mutation and RANX1 T1 mutations, and patients who are undergoing transplant, the chimerism analysis was tested for sorted CD34 117 peripheral blood cells. So MRD positivity was defined as a decrease in the CD34 or CD117 positive donor chimerism to less than 80%, or if there is any detectable mutation more than 1% in NPM1, they are considered as MRD positive. So with 6 months of starting the MRD guided therapy, approximately 61% of the patients, they were in complete remission, Out of them, 37% they had a complete hematological relapse occurred at the median of 3 cycles. So 46% of the patient, there was either decline in the MRD below a predefined threshold. After 6 months of initiating the MRD-based treatment, half the patients were subjected to, they were receiving the median of 6 other subsequent ASA cycles. Hematological relapse did occur in these 1/3 of the patients, but it was delayed until a median of 320 days after the initial MRD detection. So with median follow period of 9 months after the start of MRD guided preemptive treatment, the 12 months overall survival was 94% and PFS was 44%. So next is the VALDAC study. So in this the patients in first morphological remission, either their MRD relapse or oligoblastic relapse, 5 to 15% bone marrow blast, with not more than 1 line of intense chemotherapy, including transplant. So MRD relapse was defined as more than 1 log increase in the molecular MRD. And patients are subjected to venetoclax 600 mg once daily for 1 to 21 days in combination with low dose Arasi for 10 days. So NPM1 mutation was analyzed using RT-PCR, and for IDH1-2 mutations using digital droplet PCR, and response was assessed after cycles 1, 2, 5, 8, 12, 16, 20 and 24 using the ELN22 criteria. So here you can see the rate of infections and neutropenia and anemia was very higher in patients who are having a oligoblastic relapse rather than a MRD relapse. The rest of the things were almost same. Coming to the response rates of MRD negativity and the oligoblastic clones. So the patients who are subjected to the preemptive treatment, approximately by the end of 4th cycle or 5th cycle, around 50% of the patients they become MRD negative, and more than 3 log reduction is present in rest of the patients, like around 60%. And coming to oligoblastic relapse, the response rate is by the end of 4 cycles or 5 cycles. When put together, both the complete remission and the CRI, complete remission temporological, incomplete temporological recovery, is close to 70%. And by the end of 2 years, overall survival is close to 67%. And in case of MRD negative, it's on 53% only if it is a oligoclonal relapse. So intervening the patients is important if the patient is having MRD negative relapse. Relapsed at a MRD level itself. So is there a role of blina in core binding factor AML? Because A21 translocated AMLs, they can have CD19 as a aberrant expression, and this blina is a targeted molecule. It's a bite against CD19. So this was used in patients of multiple relapsed AML with prior to transplant and not responding to with transplant, and they were not responding to a salvage DLI. So the data is naive. So avapritinib for patients of KIT inhibitors, it's a KIT inhibitor for patients of AML with KIT mutation. The 20 patients of baseline KIT mutation at diagnosis, they said continuous avapritinib 100 milligrams once daily for median of 5 months for MRD relapse. With 1 month of treatment, the overall response rate was 60%, and out of them 10% they achieved MRD negativity. About half of the patient they MRD negative. Only the follow-up was very short. So moving on to FLT3 ITD mutation. FLT3 ITD, though we said this is a subclonal event, it cannot be used as a target for molecular monitoring. So there are data on the monitoring of AML FLT3 ITD mutations for patients who are on inhibitors of FLT3 using NGS MRD technique. So this one highlights the FLT3 inhibitor as a MRD guided salvage treatment for patients of molecular failure in FLT3 mutated AML. So FLT3 mutated patients, if they're going to relapse, frankly, then the response rate is only going to be very poor. It's somewhere around 6 to 9 months only. That is shown with the Admiral study and Quantum R study with gilteritinib or quizartinib. So outcomes is very poor. So if you're going to treat the patients with the molecular relapse itself, so that is what this study highlights. 56 patients treated with the FLT3 inhibitor at a molecular failure. About half of them they have previously received midostaurin. So molecular failure occurred in at a median of 9 months from the diagnosis, and they were treated with gilteritinib in most of the patients, and quizartinib and sorafenib with the rest. About 60% they achieved a molecular response, and 45% they reached MRD negativity. The toxicity was very only low, and 22 of the patients they were bridged to allogeneic transplant. With 6 of the patients they received DLI, and 2-year overall survival is 80%, and molecular EFS is 56%. And patients are gilteritinib maintenance following transplant. So pre-transplant MRD status of FLT3 that is very important. That matters a lot. So if the survival probability is higher, is for patients who are having a MRD negative status prior to transplant, or if the patients are MRD positive prior to the transplant, if you're going to give gilteritinib, they're going to benefit a lot than patients who are having a MRD negative status. The relapse-free survival is better if the patients are subjected to gilteritinib if they're having a MRD positive status prior to transplant, than not giving any treatment for this patient, just putting the patient placebo. So regular monitoring for patients for FLT3 inhibit ITD MRD using a PCR NGS technique should be the standard of care, and gilteritinib maintenance for 2 years post-transplant is important. This is beneficial, especially in patients who are having a pre-transplant MRD positivity. Gilteritinib maintenance is very much helpful in such patients. So pre-transplant MRD status, does it help in deciding conditioning regimen? Yes, there is impact of conditioning regimen in patients of AML undergoing allogeneic transplant. So this study shows these mutations of various mutations and their VAF. So in this, the patients who are having a MRD negativity prior to the transplant, the overall survival is not going to improve whether they are subjecting the patient to myeloablative or a RIC. Whereas if the patients are MRD positive by NGS, the myeloablative takes a superior hand. So if we're going to treat the patients with the conditioning, myeloablative conditioning, for the patients of MRD positivity, the survival is better than subjecting the patient to RIC. The relapse is also higher in patients who are having NGS MRD positive and subjected to reduced intensity conditioning. So the best will be NGS negative, and either of in the patients negativity, achieving NGS MRD negativity is very important. And depending on the patient's fitness status, you can take a call about giving a MAC or a RIC regimen. And haploidentical, this study from Japan highlights from China highlights haploidentical allograft is superior to matched sibling donor transplant in eradicating the pre-transplant MRD positivity. But this is based on a flow cytometry based monitoring. The patients who are having a negative MRD had a lesser incidence of relapse than a positive MRD in matched sibling donor transplant, whereas the response rates was and the survival was relapse risk was similar in patients of both MRD positive or negative. Irrespective of the MRD status, haploidentical transplant helps. So it abrogates the negative effect of MRD positivity. So the patients who are transplanted, so you can choose, you can try giving them a preemptive DLI for MRD positive status, or a mixed chimerism, or a prophylactic DLI can be given in patients who are high risk, even in a complete chimerism and a molecular remission status. So 5-year overall survival after the preemptive DLI was around 51%, and having mixed chimerism, it's close to 68% in this patients among the responders. The 5-year cumulative incidence of relapse was around 30%, and non-relapse mortality was around 12%, and leukemia-free survival is close to 60%, and overall survival close to 65%. The GVHD rates was not higher. Acute GVHD was close to 12%, whereas chronic GVHD is present in approximately 1/3 of the patients. 6% of the patients died from DLI-induced GVHD. But the risk factor were DLI-induced GVHD is higher in patients who are elderly, and they were having an advanced stage of transplantation, and short interval from the transplant they are having the molecular relapse. In such patients, or patients who are having a prior acute GVHD, all these patients they had a higher propensity to develop a DLI-induced GVHD. The limitation of this was a registry-based study, and MRD testing was not centralized. So AML M26 intercept, this is from the Australian leukemia lymphoma group that enrolls the patient in CR1 or 2, followed by sequential MRD monitoring and a preemptive therapy at MRD relapse. So the therapy choice is not randomized, but it was genome guided. The primary response endpoint is MRD response, and secondary endpoints are relapse-free survival, overall survival, and time and duration of MRD response. So this is it. So the patients, based on the fitness status and the ELN criteria, they are standardized to receive either intense or a less intense chemo, and following which they are monitored. If there is a MRD relapse is there or a oligoblastic relapse, they are subjected based on the mutation and the MRD marker. They are chosen for the targeted therapy. Say for NPM1, they have given a low dose aracid along with ven, or IDH1, they have ivosidenib along with venetoclax. Similarly, for FIL3, they have gilteritinib along with venetoclax. And the MRD was a central MRD monitoring. So the MyeloMatch NCA, National Cancer Institute, so they have a tier system of treating the patients for enrolling them into multiple trials to eliminate the disease. So this is a master screening and reassessment protocol. The tier 1 treatment trials are for the patients who are newly diagnosed of elderly or young adult or MDS AML patients. And tier 2 assessment trials for patients who are in complete remission and based on the MRD pediatric AML is a My Child Not One trial. The gene fusions which are amenable to molecular MRD were identified in 75% of the patients, and achievement of CR MRD negativity at the end of treatment was associated with higher relapse-free survival and lower incidence of relapse. In the AAVOP group also shows the fusion genes in 67% of the patients enrolled in the 2013 Not One study showed a CR MRD negative associated with the improved EFS. So this sums up the entire talk. So based on once the disease is identified, we have to subtype the patient based on the ELN with a favorable, intermediate, adverse risk group. Obviously, we have to take into consideration the patient's age and fitness and other comorbidities, and based on that, we choose the treatment either intense or less intense. More nowadays, now we are giving more stress or importance on the targeted molecule, especially the wanted drug venetoclax. And molecular monitoring is also advocated for patients who are having a fusion transcripts and also NPM1. And based on MRD, we take a call whether to transplant or not. So my understanding is with the patients, even if they're having a standard risk mutations, like NPM1 or 821 inversion 16, if they are, you have to sequentially monitor such patients, and even before like approximately 1/3 of the patients, like around 30 to 40% of the patients of so we say, though we say it is a good risk mutation 821, it is 821 itself is a very heterogeneous disease actually. 821 AML itself is very heterogeneous. Approximately 30 to 40% of the patients, they do relapse. This is because of numerous other co-occurring mutations, and the mutation dynamics keep changing. So you have to monitor these patients molecularly, and you have to take a call before the patient goes in for a full-blown relapse. You have to take an action based on the MRD status itself, and do give the targeted molecules and take the patient as a bridge to transplant. And following transplant also, yeah, you can intervene based on the MRD, whether the what kind of conditioning you're going to use, and when to use a DLI, and de-intensification or the tapering of immunosuppressions can be considered. So thank you all for the patient listening, and a happy Diwali. Thank you. I thank MBA Agrawal sir once again for this wonderful opportunity, and MSG for this, and the audience for patient listening.
Thank you, Ramesh, for wonderful, wonderful lecture. You explained us everything and updated us beautifully. So we have a couple of minutes for discussion. I'm sure, yeah, Dr. Roshni, please go ahead.
Thank you for that very wonderful perspective. The first question is, does bone marrow cellularity affect the MRD?
Sorry, ma'am, bone marrow cellularity?
Does it affect the MRD interpretation?
Obviously, like bone marrow cellularity, more than cellularity, I would say the first pool has to be from the for the MRD.
MRD.
So that should be like, if it is dilute, definitely the results are going to be not very. You cannot be very confident telling it's MRD negative.
And the second question is, do all patients need MRD? I mean, those patients on less intensive treatments, will MRD help to reduce the cycles of venetoclax we give?
Yeah, very nice question, because right now, like we start the patient for the patient is elderly. We start the patient on less intense therapy. We start Azaven, and we do not know the endpoint. The patient keeps on asking the same question, like when will my treatment end? I'm doing well, so I'm free of transfusions, and how long should I continue? This one question is there with even the clinicians and all the patients. Obviously, they're asking the same question. So my kind of practice is, what I do is, like initial 6 months, like I give monthly, then and I used to discuss with the patient, and then I like prolong the duration of treatment, like not giving monthly, but rather than like every 45 days I tend to give. Then I like extend it, like then I give every 2 monthly. Somehow that is what I have been practicing. So if there are, the others may be practicing in other different ways also.
Thank you, Dr. Roshni. We'll take
Thank
two.
you. Yeah.
One from Dr. Sushma and one from Dr. Upendra. Yeah.
Very informative talk, sir. Thank you. I actually have a couple of questions, but I'll ask only one. So, sir, for this NPM mutated group of patients, as we come across, they are usually elderly. So, are you, for the NPM MRD, are you following the Outman paper of doing it after 4 cycles?
Yeah, I used to follow after 4 cycles only.
And
Though
beyond
they
that,
say at the end of
okay.
2 cycles, but I don't do it at the end of 2 cycles.
Yeah.
I do it after 4 cycles. And then based on that,
And
every 3 monthly.
every 3 monthly you are doing, sir. And this group of patients, like you have already actually told about that, the patient doesn't have any bad mutations with it, no DNMP3 and no NRAS, KRAS. We actually have a couple of patients who have crossed almost 3.5 years on Azaven. And we also do that. We space out and keep Velva for 5 days, then for 1 week. So, because there are recent publications of stopping the drug, what is your look into it?
Yeah.
Ramesh, you're not audible.
Yeah, obviously that you can choose like also. Maybe like instead of, sir, is it audible now, sir?
Now, yeah.
Yes.
Is it audible now, sir?
Audible, yes.
So either you can like cut short the duration of the cycle, like maybe instead of 7 days, you can cut short to 5 days, or from the venetoclax 14 days, you can cut down to 10 days. Like it's not like standardized. It's not like hard and fast.
Thank you. Thank you.
Thank you. One last question from Dr. Upendra. Quick, short question, short answer.
Thank you, Agrawal sir. Dr. Ramesh, very wonderful talk. So, those patients who are low risk AML, favorable risk AML, post consolidation, if they are MRD positive, so how do you follow those patients? Either observe or any maintenance of hypnotic agent or transplantation?
Initially, I don't straight away take up for transplant. I do. I don't straight away give the treatment also. Like I don't start preemptive therapy immediately. Just with the one MRD positivity, I wait for the month. I give one more cycle of the same Azaven. Then I do test it after a month. If it is still persistently positive, it's progressively increasing, then I do consider the patients for transplant.
Okay.
Thank you, sir.
Right. So thanks, Ramesh. Thanks to all the discussants for this lovely morning discussion on subject of MRD guided treatment. It was very, very useful. And I'm sure it will help all the listeners in improving their practice. So we now move on to the second webinar this morning. And Dr. Claire Harrison has already joined. It's my pleasure to briefly introduce her. She has been our regular teacher, professor, either in person or through the webs for last almost a decade. I think everybody in India and across the globe have learned a lot about the subject of MPN and fine-tuned their practice because of listening to her. Today, she's going to speak to us on polycythemia vera and its treatment in 2025. For the formality's sake, she is professor, deputy medical director, research and clinical director, Department of Hematology at Guy's and St. Thomas's, London. She's an international expert on myeloproliferative neoplasms. Her education was in Oxford University, University College Hospital, and Great Ormond Street Hospital. She's recipient of Daniel Medical Fellowship 2012 and achieved NIHR Clinical Researcher Award in 2017 and 2018. She has been Tisch Visiting Professor of Hematology at Mount Sinai from 2012. She has influenced major advances in MPN, including the description of key mutations and leading global clinical trials, including the first JAK inhibitor trial in Europe. She's the chief investigator of several other international and national clinical trials. She has strong international collaborations in France, Germany, Spain, and the US, amongst others. She has authored innumerable papers in peer-reviewed journals, including NEJM and Blood. She regularly contributes to British Society of Hematology and the European Hematology Association. She is a founder of MPN Voice. She is an advisory member for the MPN Education Foundation. She collaborates with MPN Research Foundation. She also works with other patient charities such as Blood Cancer UK and MPN Research Foundation. She is an advisor to the Leukemia Care and Bloodwise medical charities. And today, as I mentioned, she'll be speaking to us on polycythemia vera treatment in 2025. So over to ma'am.
Well, good morning. Thank you very much. I must remember to give you a much shorter introduction. Me. Anyway, it's my great pleasure to join you this morning. And I wish I had known about the earlier lecture because I really enjoyed the discussion. I hope you can hear me well enough.
Yes.
Perfect, good, because sometimes the microphone's not so good. So we're going to talk about polycythemia vera treatment. As we all know, acute leukemia, when it arises for those patients, is an absolute disaster. So hope not to have to think about that. These are my hospitals in London. But really, it's always been my great pleasure and privilege to join these meetings and meet colleagues and discuss patients from across the world. So I always like to think about history when I think about sort of giving a perspective lecture. And this is Vaquez. And Vaquez was the first person to describe polycythemia vera, which has been known by several different names, as you can see. And he described this disease in a 40-year-old man. You can see the clinical description: chronic cyanosis, distended veins, etc., and marked erythrocytosis. So this is really interesting. This is how perhaps we would recognize this condition today, although we have a very clear way of defining it based on molecular tests. This is also important because many of us are taught, and the statistics tell us that these diseases generally occur in patients in their 60s. But actually, polycythemia vera occurs in 20% of patients under the age of 40. I don't know what the demographic is, for example, in India, Mumbai, and elsewhere, but this is definitely true in London. And this is also true, of course, in ET. Now, I want to talk a little bit in the context of a clinical case. This is a real case, as you'll understand as we get further on. This is a patient referred by his family doctor. He did a routine test, and he had a little bit of symptomatology that made us suspicious about his diagnosis. The itching, feeling tired. There's nothing really of note in his medical history. He was working as a principal of a very big sixth form college. His laboratory results were highly suspicious that there was a myeloproliferative disorder. Why do I say that? We have quite a lot of patients, I'm sure you do too, who are referred with a high hemoglobin, but this patient also has a raised platelet count and a raised or upper limit of normal white cell count. Furthermore, the serum iron was low, that's suggested by microcytic indices, and the vitamin B12 was high. And in the past, a raised vitamin B12 was actually a diagnostic criteria for polycythemia vera. Currently, our diagnostic criteria are generally based on the WHO and ICC, and then this is one of the areas actually where the two diagnostic criteria don't really differ very much, except the WHO, we abolished the need for red cell mass. We said it wasn't really necessary. I still use it if I find a patient has a high hematocrit and I can't find another cause. So it's still a useful test, but not necessary really to diagnose PV. These are the BSH guidelines. Usually there is a question about what do we do about JAK2 negative polycythemia. So in the British Society of Haematology, we were very careful to list out lots of criteria that would make us make this diagnosis in this setting, but I would say it's very rare to diagnose PV in a patient lacking a mutation. And you can see that I've highlighted here the importance of a bone marrow biopsy, which is particularly important in this setting. I can share with you that in recent discussions where we've been discussing merging these entities, which of course is probably very helpful in other hematological oncological conditions, in particularly MDS, where the differences between them is really not helpful. We have been discussing the fact that we might say that if the patient doesn't have a JAK2 mutation of some description, then they do not have PV. But we haven't got there yet. Moving on with this patient, all the patients that come into my service with that kind of blood count would get a JAK2 test, a serum EPO. We would, of course, do an ultrasound scan, a chest X-ray, and some other bloods, but these were all consistent. He did have a bone marrow biopsy. It's not always necessary, but he's quite young. And I always think it's helpful to have it as a baseline. And I would always look for another cause of iron deficiency. I don't want to miss colon cancer in a 56-year-old. I don't want to miss it in anybody, but I think it's important to remember that patients can have more than one pathology. So this is his diagnosis. He's low risk because he's age less than 65 and no thrombosis. And where we are in 2025 is we're now thinking about, and I'll return to this idea, that some patients who we would describe as a low risk PV actually should have a treatment beyond aspirin and phlebotomy. And those patients might be those with symptoms that aren't responding to standard therapies, a raised white count, a JAK2 VAF. We'll see the evidence for this over 50%, splenomegaly or cardiovascular risk factors. So what we did for this man reflects what we would do, all of us, for our patients: establish diagnosis, risk stratify, personalized therapy, and then do this in a loop to predict complications, inform patients about disease, and then select the best therapy. So questions that patients ask are about life expectancy. So I think it's important to be aware that there is existing evidence suggesting that PV patients have a shorter life expectancy than their peers. There is conflicting evidence on this matter, and here some of it is. This is from two different databases. The first is the Real Cornell group. This is a group of Dick Silver, who's really a giant in my field. And you can see that his patients, compared to expected, had a pretty near to normal life expectancy. This group is a heavy user of interferon and interferes very much for their patients. They also probably have a younger group of patients. They're an international expert centre. This is data drawn from the SEER database. So SEER is surveillance, epidemiology, and end results. This is a route to access large volumes of real-world data. So this is patients treated in the real world, and here you can see life expectancy about 15.8 years, significantly below average. And you can see that life expectancy correlated with age, and maybe a little bit with gender. How do we risk stratify? Well, I've touched on this already because I told you how we risk stratified our patient. But you should be continually looking at this in your clinical practice. Patients don't just develop cardiovascular risk factors at the time of diagnosis, they develop it during the course of their disease. As they do progressive leukocytosis or extreme thrombocytosis, so for me that would be a platelet count of over 10 or a white count that's going above 15. We could talk about frequency of hematocrit. There's various evidence for that. And I've spoken about some of these. Also some evidence around reticulin grade and abnormal karyotype defining risk stratification. Concerning the high JAK allele burden, and by high, we refer to a VAF of less than or greater than 50%. Interestingly, in this data from Paolo Guglielmelli in Italy, the high JAK2 VAF correlated with venous, but not arterial thrombosis. And this remains significant in a multivariate analysis. So something that we could consider in addition to conventional risk factors. A high JAK2 VAF also predicts or correlates with, let's say, the presence of pruritus and splenomegaly. Importantly, also here you see cumulative incidence of myelofibrotic transformation, and here you can see myelofibrosis-free survival. Again, this may justify the use of a therapy to moderate, certainly this as a complication, if we believe such a therapy exists. And there is increasing evidence that we may have therapies that can do that. Just on the topic of molecular profiling, is there any value in doing an extended myeloid gene panel to look for additional mutations? Well, there is some data, but I would say in routine clinical practice, it is not of value unless you want to better characterize your group of patients and you have funding to do so, or, and this may be important, you have a patient who has some atypical behavior clinically. Here you can see in a clinical study that we performed, event-free survival was worse in those patients who had ASXL1 mutated disease, and this is the mutation on the left, enhanced international prognostic score in PV. Here you can see SRSF2 mutations coming in with quite a significant weighting equal to age and abnormal karyotype. In clinical practice, I have to say I don't use this score. Don't forget basic cardiovascular risk. I know that you're all really busy in seeing patients. I think I'm busy, but I know you're really, really busy. We use Q-Risk3 and have analysed our patients at Guy's and St Thomas's. This is an online tool used by family doctors for calculating a 10-year risk of heart attack or stroke. I had mine calculated recently. It's online, and the readout is something like this. We looked at this in our patients with PV and ET. Here you can see the ET cohort, and a threshold of 7.5% was useful in identifying patients who were at higher or lower risk of thrombosis. Just to put this in context, I don't have PV. If I went to my GP, they would not act on my Q-Risk3 unless it was greater than 10%. So that illustrates that our patients are more impacted by cardiovascular risk. And here you can see some work we did using conventional age or less than or greater than 60 years and prior thrombosis. And you can see the presence of a Q risk for these patients. Here are the low risk patients with a Q risk less than 7.5. Here are the low risk patients with a Q risk greater than 7.5. So it further stratified conventional risk. My patient asks, is this a cancer? Is it inherited? And what are the implications for my long-term future? I won't go into these answers in detail other than to say, in the UK, we would say that our patients have a cancer. This is a clonal disorder. It shortens their life expectancy. And importantly, saying this is a cancer elevates the importance of this condition in my patient's mind, but it also will allow them access to a specialist nurse and ways of getting cheaper medication. Is it inherited? Well, there could be a whole lecture on this subject. There is evidence that certain sequences, so SNPs, within the JAK2 gene and in other areas, such as in the TERT gene, but the JAK2 46.1 locus does seem to predispose to the development of PV. And I think we've already gone over the implications for long-term future. This patient is, as I said, a low-risk patient. And just to put in context, we perhaps shouldn't use low risk, certainly in the context of thrombotic events. Here is some data from the general population without cardiovascular risk, with cardiovascular risk, and here are conventionally defined low-risk PV patients. So you can see their risk of thrombosis is significant. And we haven't done a good enough job to return this back to normal for either groups of our patients. The British Society recommendations for management of low-risk PV are shown on this slide. There should be no surprise for you, and they now reflect considering cytoreductive therapy in low-risk patients with the additional risk factors we discussed. So my patient starts treatment with aspirin and venesection. The data supporting the use of aspirin in PV is much stronger than for ET, for example. It comes from the ECLAP study, and for venesection to a target of less than 0.45 compared to 45 to 50. So do not let your patients, what I say to our resident doctors, don't let the patient out of the door just because their hematocrit is 0.453. You need to act on it. So patients with a higher hematocrit target were 4 times more likely to die from cardiovascular causes or major thrombosis. The evidence for starting cytoreductive treatment in low-risk PV comes from multiple places, but there has actually been a clinical trial conducted by Tiziano Barbui, and somebody else who's mentored me throughout my career and is a shining example. And he treated some young patients with Ropeg interferon, which is a longer-acting formulation of interferon. And the benefits for these patients were hematocrit control, reduction in phlebotomies, and absolute change in JAK2 VAF. They defined disease progression in a slightly odd way in this study. You can read the results, but effectively persistent need for phlebotomy or thrombocytosis were progressive risk factors. There were no differences as yet in myelofibrotic transformation. We treated our patient with aspirin and phlebotomy, but over time he became more and more symptomatic. You probably recognise what I describe on this slide for your patients: very tired, still itching, frequently coming to hospital. His platelets go up and his white count is now 17. And so we made the decision to offer cytoreductive therapy. And right now, this would be either hydroxycarbamide or interferon alpha. This is still off-label, but increasingly, we are recommending this as a first-line choice for younger and younger and younger patients. When I first started in the field more than 2 decades ago, our recommendation would have been for young patients of childbearing age. Then we didn't have the longer-acting, more tolerable interferons. So we only had unpegylated interferon. And these are agents that are very different. Routes of administration is one thing, but the side effect profiles are very different. We know that the benefits of hydroxycarbamide is significant in ET. We have less good evidence in PV. So in ET, this is the Cortolazzo study from 1995. Here you can see the benefit of hydroxyurea, and this is just targeting platelets less than 600. It's a reasonable correlation because around 60% of our ET patients will be JAK2 mutated. There have now been several randomized studies comparing interferon with hydroxycarbamide using pegylated versions of interferon. This is one that we contributed to from the UK, so-called MPD-RC study. It was published in Blood 3 years ago. It's a nice study, but unfortunately, it's limited by the fact that we were not able to continue to treat patients beyond 12 months. In these diseases, we need to treat large number of patients and follow them up over a significant period of time to show differences. But nonetheless, I'm showing this data because it does show that both agents can lead to complete response and indeed an overall response. That's CR plus PR. But maybe a hint that for PV, you may see more overall response with interferon. There is another study where they have been following patients up for longer. This is the slightly different formulation of interferon, Besremi, in the continuation PV study. These patients were also slightly different when they entered the study. They could have had hydroxyurea, but they shouldn't be in a complete response. And at 5 years, there was a trend towards more complete hematological response, control of all the facets of the blood count with interferon, but it wasn't significant. But molecular response was more common. No difference between treatment-related adverse events, but of course the spectrum of events was slightly different. More recently, this group have used an endpoint which we started to use in the UK in the late 1990s, called event-free survival. I'll return to it later, but effectively event-free survival is thrombosis, hemorrhage, death, transformation, and those are the main endpoints. And you can see that there was a benefit here which was significant for the interferon group, but that did not become so until almost 7 years. One of the things that puts people off using hydroxycarbamide is a question mark about long-term risks. There still remains a question mark. This is data from Sweden, and here you can see that there was no increase in risk of transformation to AML or MDS, and that indeed 25% of these events occurred in patients never exposed to cytoreductive agents. Occasionally, we do need to use older-fashioned drugs to treat our patients with PV. In the past, we have used radioactive phosphorus, not available in the UK anymore, but this and alkylating agents are linked with increased risk of leukemia. In a more recent study, there was an analysis of 3,500 patients with Philadelphia negative MPN treated with hydroxyurea. And this illustrated that about 5% of patients develop side effects. I have to say, in my practice, it's probably more than that. And I would particularly be focusing upon what we call mucocutaneous side effects, oral and leg ulcers, skin cancer. But this nicely highlights some rarer side effects which we should be aware of in clinical practice. I put my patient on hydroxycarbamide. He didn't really fancy interferon, and this was more than almost 15 years ago. And he did indeed tolerate the drug quite well. But as we see him now, he is still needing 4 or 5 phlebotomies a year. Now, the evidence on the number of phlebotomies that are needed and indication of risk to patients is debated, but for me, this threshold of 4 to 5 phlebotomies a year is quite significant. He still has an elevated platelet count and an elevated white count, and his serum iron, as we would expect, is very low. On the basis of this, he does meet criteria for resistance, but you would rightly challenge me and say, what's the dose? So you need to be on a good dose of hydroxycarbamide to call resistance. Otherwise, you should be pushing the dose up. Just to note, we use the MPN 10 score. We just hand our patients a sheet of paper, and he's scoring quite significantly here for factors that would make us want to have a conversation. There are formal criteria for resistance or intolerance to hydroxycarbamide. They're shown on this slide. Effectively, intolerance reflects the development of cytopenia, gastrointestinal, febrile, or mucocutaneous toxicity, and resistance is, of course, failure to achieve target. And whilst these are at lowest dose, this is at either after 3 months of therapy or reaching a maximum tolerated dose. I don't quite agree with after 3 months of therapy for still needing venesection, so I wouldn't be quite so stringent. Why is this important? Well, it's important because it's identifying a patient who is not well controlled, but particularly those patients who develop cytopenia. This is from the Spanish registry. These patients have an increased risk of death, and that is due to transformation to AML or ML. Whether that is reversible or not, we can discuss. These are the British Society guidelines for recommendations in this setting. So we might switch a patient from hydroxycarbamide to interferon, or vice versa, or consider pegylated versus non-pegylated. In fact, we only have pegylated interferon now, or the use of ruxolitinib, or some of these other agents. In this context, we conducted a study known as MAGIC PV, which we published a couple of years ago in the Journal of Clinical Oncology. This is not a pharmaceutical company study. This is an academic clinical trial supported by Novartis with free drug, but by blood cancer charities in the UK. Both Blood Cancer UK and MPN Voice supported this study. We didn't have the availability of ruxolitinib, and so we randomized resistant or intolerant patients to either choice of best available therapy or ruxolitinib, and it was designed to assess the long-term benefit of ruxolitinib, and we built in other endpoints such as molecular response. We did not allow crossover for patients, and you can see all the embedded things that we did here. We found that ruxolitinib was superior to best available therapy for achieving a complete response. This was already known and had led to the approval of ruxolitinib, but nonetheless, it's important that we were able to show this in our population of patients who reflected more real-world practice. So we allowed patients who had been intolerant or resistant at any time. We allowed patients who'd had a cancer. All of these things would exclude patients often from commercial trials. But we also found that ruxolitinib was superior to best available therapy for this endpoint, event-free survival, which I described to you earlier. And so for ruxolitinib, there was a 42% reduction in these risks for patients. If you break these endpoints down into individual facets, you can see that they are all trending to significance, and the most significant trend here is for thrombosis, but added together, they lead to this combined endpoint. Just on the point of venesections, I think that ruxolitinib is a highly effective therapy for reducing the need for phlebotomies. You can see the overall number of phlebotomies in the trial here is strikingly different. And returning to this theme of number of phlebotomies in a slightly different way, in our study, the time to first thrombotic event correlated with the mean number of venesections per year for our patients. So it is worth just counting that up for your patient. We also asked a question about obtaining a complete response. Regardless of treatment, did that lead to better event-free survival? And the answer is yes. So you should be aiming for this for your patients. So this was associated with an even bigger reduction in risk of events. We saw continuing benefit for symptoms. This is novel data because in commercial trials, patients often crossed over. We designated some adverse events of special interest. These were infections, not different, and malignancy transformations, different in type, but not in number. Skin cancer, particularly a problem for our patients, for other cancers, not. We did see an increase in zoster, and so in my practice, I would vaccinate patients against zoster using an inactive vaccine. What about molecular response as a treatment goal? So molecular response is associated with event-free survival in the MAGIC-PV study. Here you can see that at 12 months, and here you can see the blue bar patients, ruxolitinib patients. Ruxolitinib led to greater frequency of molecular responses at the later time point. At later time points, these people who did all of the work in this analysis, we were able to show that progression-free, event-free, and overall survival were significantly better for patients who had a molecular response. A moment to emphasize, this is not MRD. We were talking about MRD as I joined your excellent meeting this morning. In this study, it was just a 50% reduction in VAT. This has also been shown in the Proud and Conti PV study. Here you can see the difference with interferon, and here you can see event-free survival for molecular versus no molecular response. And so we've now reviewed some of the evidence for ruxolitinib as a second-line therapy, and now you see the face of Mark with his permission. He was our first patient on the MAGIC-PV study, and he did extremely well on that study. He's still on ruxolitinib. He started in August 2012. He didn't really have any side effects. He hardly ever needs a venesection. He's enjoying life now, having retired, but he retired on his terms, not because he couldn't manage with his disease. And he's a good ambassador for patients participating in research. So we've reviewed some of the data for management of polycythemia vera in 2025. I showed you some novel data with regard to, for example, the use of the QRIS-3 score, and we explored a bit about molecular responses, but I also emphasized to you cardiovascular risk, controlling the blood count, and where you might consider tweaking therapy. I now want to spend a little bit of time looking at new therapies on the horizon. And I'm just going to tell you that these slides came from a lovely colleague, Susanna Isfor, who presented this data at the IACH meeting last weekend. She spoke about different targets, and these included influencing iron metabolism. There's a lot of interest in this at the moment. Histone deacetylase inhibition, LSD1 inhibition, and others. Let's talk about iron metabolism in PV. Mark was very iron deficient. Most of our PV patients are very iron deficient. The central role of hepcidin in regulating iron, I have had to revise and learn about again recently. Hepcidin is a central regulator of iron. It affects iron absorption, recycling, and release from stores. And its expression is enhanced by the iron regulatory pathway, inflammatory cytokines, and it's suppressed by erythropoiesis. In PV, hepcidin expression is suppressed. In myelofibrosis, it is enhanced. And so these pathways are targeted in opposite ways in these conditions. So there are new substances influencing iron metabolism. The first one of these to be developed is rusfertide. It is a hepcidin mimetic. In the presence of rusfertide, which was known as PPG-300, it mimics hepcidin. Ferroportin is closed. You don't absorb as much iron. and iron release to the bone marrow is reduced. It's been tested in several studies, and data was published in the New England Journal of Medicine quite recently. In these studies, the green therapies relate to individual patients, green lines reflect individual patients swimming along in the swimmer plot who received rusfertide. The red dots, won't surprise you, you could guess, these are phlebotomies. In this study, they also did a randomized double-blind stop. Those patients who stopped, you can see they started needing phlebotomies again. There was also a benefit of this therapy in symptom scores, but for me, I'm only more interested in whether the symptoms were more apparent in a placebo-controlled or randomized setting. There are other agents that are targeting the iron pathway. So antibodies to hemojuvelin, small inhibitory RNAs targeting TMPRSS6. And all of these are being developed to reduce the need for phlebotomy. I think this is important for our patients. I don't want to underestimate that. But for me, I think the PV field is moving more towards comprehensive count control and potentially towards molecular responses, which we can get with interferon, ruxolitinib, and to a lesser extent, hydroxycarbamide. Unless these therapies are very cost-effective or low cost, I don't think many of our health economies will be able to afford them, but nonetheless, for some patients, they will be valuable. Other agents, HDAC inhibitors, these work by targeting epigenetic regulation, and they also target the JAK-STAT pathway. We used vorinostat in a clinical trial some years ago in the UK, and there is an ongoing study with givinostat. The LSD1 inhibitor also targets epigenetics, and it has been used in ET, and there are randomized studies using this drug, which is an oral agent in ET. It can target inflammation, fibrosis, proliferation, apoptosis, and it does lead to reductions in allele burden. There is a phase 2 study, which is an oral at ASH concerning bomedemstat in PV. This is the data in ET. In the interest of time, I won't show you too much, but you can see there's control of the platelet count, there's reduction for patients with all different mutations, but there are quite considerable side effects, including interesting ones that we don't usually encounter for our patients. So you see 50% of patients have dyschezia, so altered taste. Arthralgias, 25% of patients. What about other targets? Now, these may be more of interest to you. So N-acetylcysteine, a relatively low-cost therapy, reduces inflammation, and there is a study ongoing looking at the use of this agent to reduce symptom burden. We certainly know this is an area of unmet need for our patients. And interestingly, in this study, they're also looking at the gut microbiome. Methotrexate, a drug that we also, all of us have in our pharmacies. In New York, they're looking at this drug as an agent to treat myeloproliferative neoplasms. It is a type 2 JAK inhibitor. And so there are cases reported in the literature where this agent has actually controlled blood counts in patients who happen to be receiving it for rheumatoid arthritis, and they have an MPN. So there's a high potential for use of this drug in countries and in populations where everywhere across the world, actually, where we would want to keep health costs down, but also use a drug that has been used for many hundreds and hundreds of patients for a long time. So we know a lot about safety profile. I would have to say I still have anxiety about use of ruxolitinib, for example, and we are using that drug in a randomized study in a first-line setting in PV. anxious about giving that drug to patients who are under 40 because I don't know about long-term risk. So I'm happy to have shared with you Susanna's studies slides, and I'm really grateful to her for being so generous, as many of my colleagues are, in sharing data and slides. But I think it's important to think about targeting iron and reducing inflammation for patients with PV, and to reflect that the story isn't done yet. I want to close here perhaps a little early, thanking colleagues from across the world, thanking all of you for your recurrent and very kind offers to have me speak to you on a Sunday morning. It's always my pleasure. I want to call out the home team at Guy's and St Thomas's. This is Richard Dillon. You were talking about Jad Ordman's paper this morning. Richard and Jad worked together on that paper. This is Sue Robinson. She has led much of the work defining pregnancy management. This is my lovely colleague Gypsy Radia. She worked on mastocytosis. Natalia, Jennifer, and others worked on molecular responses, as did Joanna Baxter and Jyoti Nangalia. And I also want to thank my family, who've put up with years of me working long hours, like many of us do, and talking passionately about these diseases, but also to my patients and patient advocate colleagues. So thank you very much, Professor Agarwal and colleagues. I'm very happy to take questions. I know there are always lots and they're always excellent.
Thank you for that wonderful update and clarifying so many issues. We heard you so many times, but each time we learn more and more from you. So
you're very kind.
We will take up some questions from the colleagues here as well as from the chat box, starting with Dr. Roshni.
Good morning, ma'am. Thank you for that excellent lecture. It makes some of my concepts more clear. Is there any way to delay or to prevent transformation in PV?
Well, I think that we have seen emerging data in the last couple of years that suggests that is the case. There are statistical trends from older studies suggesting that if we use older-fashioned drugs like hydroxyurea, we do see less progression to myelofibrosis. But increasingly, there is evidence that therapies, as I showed you, to lower the JAK allele burden as a marker may reduce the risk of progression. But you did see in the slide with the MAGIC PV that we saw an imbalance in types of progression. How will you know that you're reducing the risk of progression for your patient? I think you would want to see complete control of the blood count and perhaps some more modest reduction in the JAK2 allele burden. We're currently exploring how much we should be reducing that by. There's some work from colleagues in Italy that suggested the deeper the molecular response, the lower the risk of myelofibrotic transformation. And we need to do some more work to define that. So I would say yes, as evidenced by control of the blood count and perhaps reduction of the JAK2 VAF, and yes, particularly with interferon and probably with ruxolitinib. Thank you.
The second question is very basic. In a low-risk patient of PV, when should we use hydroxyurea, especially when the patient has a normal WBC count and normal platelet count?
Well, if that patient has a lot of symptoms such as fatigue and itch, and you've used all the current standard therapies such as antihistamines, etc., that we might use for those, I would sometimes use a trial of treatment. If the patient is requiring a lot of phlebotomies, again, I would sometimes use a trial of treatment. If the patient has progressive splenomegaly or cardiovascular risk factors, even perhaps if they're well controlled, still having hypertension, even if it's perfectly controlled, still increases your risk. But I think you have to put that in the context of the risk of years of therapy for the patient. And there's also a financial burden of that for our patients as well. JAK2 might be helpful. I would probably take that into account as well.
And when do you do molecular profiling of patients? When they develop cytopenias, they develop resistance, or some other time point?
Excellent questions. So at the beginning, if they are a very young patient, if they're less than 25, I might do molecular profiling because I'm just interested in those patients and I want to know what's there. If they have atypical features, so persistent basophilia, very high white count, splenomegaly, probably would do it then. And if they develop signs of resistance, I would do it then. Particularly cytopenias, as you very smartly pointed out. I just want to say, though, that despite the fact that we showed in the MAGIC PV study that the presence of additional mutations means that the patient's less likely to get a molecular response, it wouldn't change my therapy. I don't have any evidence that I should choose a specific therapy for a specific profile of patient. So you could question the value of that. Karyotyping, I think, is useful in less often, and we don't routinely do it for our patients.
Thank you so much.
Thank you so much.
Thank you, Roshni. Upendra?
Dr. Clary Harrison for that wonderful talk on PV. So some new points in this. So we usually not doing this Q risk 3 score. So you're doing this risk scoring for all of your patients. So a low risk patient of polycythemia having high Q risk score, do you prefer using cytoreductive therapy in those patients?
Yeah, I didn't say what I did I? Thank you so much for pointing that out. So the Q risk 3, first of all, to say that it includes the postcode or zip code for patients in the UK, because the data is also built on deprivation, pollution, etc. But it is still useful internationally. We've been looking at it in Sicily, for example. The first thing I would be doing with that patient is I would be looking at their vascular risk and asking them to moderate it. In our centre, we are lucky enough to be able to refer a patient to a cardio-oncologist who knows far more about managing vascular risk than I would, and knows more, for example, about use of specific statins. And in that circumstance, yeah, I would think about tighter control of the disease, because I think that we could probably gain equally from controlling the vascular risk, but I would still be thinking about. And in fact, if you look at that paper, we show that if we just take the cohort of PV patients that have low risk disease, they're less than 60, and they've got a Q risk of more than 7.5, if they are patients who we have started on a cytoreductive drug, they are less likely to have a thrombotic event than patients who have not started. So there is a hint in our data set of nearly 1,000 patients that, yes, adding a cytoreductive drug is a good thing to do, but it's relatively weak evidence.
Second question, sir, can I ask? So you pointed that some say young patient, 25-year in last question. So with abnormal features, say splenomegaly. So do your mutation profile in those patients? So say some adverse mutation profile T2 AXL mutation is found in those patients. Do you prefer giving hydroxyurea to those cytoreductive therapy to those patients?
Yeah, that's a really excellent question. First of all, I wouldn't see those patients very often. So it's uncommon in a young therapy-naive patient to have that kind of mutation. But you described a patient that where I would exactly be looking. In general, I probably wouldn't use hydroxyurea for that patient. I might be more tempted to use interferon. But there is data to suggest that responses to interferon are less frequent, and that interferon may not affect that clone, the ASXL1 clone, as well. I want to also talk a little bit about some biology of disease here. And this might be really important when we think about more mutation-targeted therapies. So we're starting to test more mutation-specific type 1 JAK inhibitors. That the JAK2 mutation can arise after another mutation. And so there can be clones that do not bear the JAK2 mutation. Slightly different in CALR-mutated disease. So if we suppress the JAK2 clones, we may not suppress the ASXL1 clone, and we could develop clonal risk, clonal drift. We don't know about that so much for these patients, but yes, in answer to your question, I would give interferon, not hydroxycarbamide, and I would be watching that patient. And I think a patient with an ASXL1 mutation, splenomegaly, where I've called the disease PV, I would want to look at the biopsy again and be absolutely sure there wasn't myelofibrosis there. Thank you.
Thank you.
Thank you, Upendra. Dr. Aishwarya.
Thank you, ma'am, for the wonderful talk. I have come across a number of polycythemia patients in their 20s, elderly, who are having the hematocrit above 50, persistently, in fact, above 55. But the MPN panel comes out to be negative. The bone marrow is again normal cellular, but erythropoietin level are low. Serum EPO levels are like less than 1%. But still, and having ruled out all other causes of polycythemia, a few of them, because of the cost issues, some of them cannot afford, but majority have been able to do the clinical exome as well. So there again, that has turned out to be negative, but they are continuously requiring phlebotomy or are symptomatic. So how do we deal with such patients? Where do we put them in?
Very difficult. Could you just educate me? What do you get when you do a clinical exome test? That's not a name of the test that I recognise.
I have 3 patients where I could isolate some mutation which is responsible for erythrocytosis. So that explained maybe the erythrocytosis. I put the patient on hydroxyurea because that gave me a solid base to start hydroxyurea, to counsel them for lifelong sort of thing, and they're doing good on that. Especially there are some patients who have challenges with venous access because of weight. So there, for a few of my patients with such a profile, hydroxyurea has been very useful. But putting someone on hydroxyurea, especially young ones, so when do I decide? How do I decide? Or should I just ask them to keep getting phlebotomy done?
Oh, your question is an excellent one. So a young patient with JAK2 negative, marked erythrocytosis and a suppressed EPO, we would be doing what we call a congenital erythrocytosis panel. So I think you've just described to me that you're doing that. In addition to those genes such as HIF1 alpha, proline dehydroxylase, EPO receptor truncations, these are the things we would be looking for. They're rare, but they do occur. I would usually ask also to look for hemochromatosis, because there is a link between hemochromatosis, at least in Western society, and a high hematocrit. I do think you mentioned weight being a marker of difficulty for venous access for those patients. Are you sure your patients don't have sleep apnea? I would be really wanting to look for another cause here, and really try not to do venesections for my patients, because the evidence for the benefit of venesection is really only in PV, and you end up with a patient tied into a clinic needing venesections, getting iron deficient, and it's a vicious cycle. In a young man, are they taking testosterone supplements to get their muscles? Yeah, no, you've asked that already.
I specifically ask these questions, rule out these possible causes. In fact, I've also incorporated doing an electrophoresis in case there are some hemoglobinopathy.
Hemoglobins, yes. So
Yeah.
does your panel rule out a high affinity hemoglobin as well? Does it sequence the alpha and beta chains?
That I need to cross-check
Yeah.
with the whole exome thing. Yeah.
Yeah,
Okay.
check. Because high affinity hemoglobin, a rare mutation, I mean, testosterone, sleep apnea, that's much more common. But a high affinity hemoglobin or another genetic cause is more common. I would leave those patients alone unless they have a family member that has a history of thrombosis. And I would, in my practice, I would be reluctant to use hydroxyurea for those patients, to be honest, because again, we're committing them to decades of therapy. So for me, I would be a bit reluctant, but it's a very difficult clinical scenario. Look at the sensitivity of your JAK2 test is the other thing.
Okay. Thank you, madam.
Thank you so much.
So, Dr. Harrison, you got 3 agents for treating polycythemia vera. You got hydroxyurea, you got ruxolitinib, and you got interferon. Now, are there clear-cut guidelines that which patient would be put on which particular agent?
Thank you so much for a very clear, very relevant question. First of all, I would not use, I'm assuming a patient needs cytoreductive therapy. I think we discussed that enough. I would not use ruxolitinib in the frontline setting for my patient. The evidence for its benefit relative to the other 2 drugs is quite low. There are financial and other toxicities of that drug, although it will become generic in 2028. We are doing a frontline study and we will have the readout from that study in about 2030. Maybe I'll come back then and tell you about that. Otherwise, in the frontline setting, I would definitely give interferon to a patient who is young and wanting to start a family. Otherwise, I would offer a patient a choice, but I would be encouraging a patient with a disease trajectory of 15 years or more, looking at expected life expectancy, to have interferon, unless, so contraindications to interferon for me are recent thrombotic event. So within 6 months of a myocardial infarction or a stroke, I would not give interferon. I would give hydroxyurea and then go back to the discussion at 6 months. There is evidence that you can trigger further thrombosis, especially cardiac one, with interferon. Other contraindications, autoimmune disease, even psoriasis can significantly worsen on interferon. And also mood disorder. You need to assess that very carefully for your patient and look at what support they've got. If they've had some postnatal depression a decade or so ago, and they've got good social support, and you're convinced that they will come to you if they do have some psychological issues with the drug, I think it's reasonable to give them. Hydroxyurea, relatively contraindicated in someone who's had a skin cancer. That's particularly a problem in Northern Europe. Otherwise, there are very few contraindications to hydroxyurea. I might be cautious if a patient's had or got some features of dysplastic myelodysplasia, for example, as well. Otherwise, I think the 2 treatments are quite interchangeable in terms of patient. But I'm generally encouraging more interferon for my patients, but I'm not so convinced that it's such an amazing agent that if my patients struggle with itching on interferon or low mood or profound fatigue, I would suggest they stop. Ruxolitinib, second line, contraindicated, I think, in a patient with active skin malignancy. That is a big problem for patients who are taking this drug in the long term. And active, deep-seated tuberculosis or other, you should sort that out before you start it. Thank you.
Thank you. Yes, Gopinathan.
Good morning, ma'am. Thanks for that excellent lecture. And I think we brought a lot of new points today. This is regarding one of our patient who recently had, he is a 70-year-old man he predominantly had erythromelalgic symptoms. So that's why his initial presentation was to a neurologist. And I think he underwent some infrared therapy. But by the time he landed to the hematology unit, he had a hemoglobin of 20, WBC of around 35,000, and platelet of around 6 lakhs. The problem is when he landed up in the hematology and ICU unit, he had altered sensorium. To a certain extent, sodium was low, but he had a lot of microcirculatory infarcts. At the same time, he also had an intramuscular hematoma. So, how to tackle this scenario between anticoagulation and giving an antithrombotic agent? How do we balance this particular scenario?
Great question. So I'd want to know about the bleeding. You know, was that intramuscular hematoma due to trauma or some kind of intervention?
Yeah, it was due to a trauma, ma'am. It was due to a trauma.
Right. So, and also asking the question, you know, is there threatening compartment syndrome or something because of that?
No threatening, no.
So microvascular symptoms are exquisitely sensitive to aspirin, as I think you're indicating. But of course, we would be worried about aspirin. I think in this setting, I missed the beginning of the case, but I'm thinking this patient's got a big thrombosis. Is that correct?
No, ma'am, not a big thrombosis, but there are a lot of small microvascular infarcts in the brain because he had altered sensorium. That's the reason for imaging, and he had a lot of microvascular infarcts.
Right. Okay. So, I mean, I think it's reasonable to use aspirin in that setting, and maybe there is more benefit for aspirin plus clopidogrel. I'd want to have a discussion with my colleagues. I think you can always watch a hematoma very carefully, and it may not worsen. There, in this setting as well, you could consider, because it's the platelets that are causing these issues predominantly, you could consider platelet pheresis to reduce the platelet count. 6 lakhs, is that 6,000 in my money? Right, so platelet cytopheresis is probably a good idea in that setting. Or high dose of hydroxycarbamide, but you have to monitor the counts very carefully. So we would be trying to set up platelet cytopheresis and using hydroxycarbamide, and I probably would give an antiplatelet agent in that setting. But it's a difficult titrate. What did you do for your patient?
Ma'am, I did hydroxyurea the same way as you said. I did hydroxyurea. I did give aspirin, but already he was started on anticoagulation also from the neurology unit. So he had slight expansion of hematoma. So what I did is I did stop the anticoagulation alone. I did continue on aspirin and hydroxyurea. And eventually over 3 to 4 weeks time, it was tough attaining a balance. As you said, as you rightly said, it was really tough attaining a good WBC balance. But over 3 to 4 weeks time, we settled on a lowest dose of Hydrea, which was actually for his age, it was sitting around 500 milligram OD, and then aspirin, 75 milligram HS. Now he's clinically stable. But initially handling him was a bit tough.
A big challenge. Yeah, I always like to understand what happens to your patient at the end. Thank you so much. Big challenge, that one.
Thank you. Thank you.
Thank you. 2 questions from the chat box. Drug that can be used for a female patient diagnosed with ET, is planning pregnancy, and who has had multiple pregnancy losses, and the platelet count is over 1 million.
Right, thank you. Well, the first thing is, in this setting, the most obvious thing to say is we need to get the platelet count down. The drug that I would use in this setting is interferon, because not only is the platelet count high, but the setting of multiple pregnancy losses indicates that we need to continue treatment through pregnancy. So for this patient, I would start, we would usually use Pegasus. I usually start at 45 micrograms every other week, escalating to a full syringe for cost effectiveness purposes after 1 or 2 doses at 90 micrograms. I would prefer that the platelet count is normalized before she contemplates a further pregnancy. And I would use aspirin And once she is pregnant, I would use also a low molecular weight heparin. So this patient gets heparin, aspirin, and interferon in pregnancy.
Right. And all these drugs can be given in the first trimester?
Yes.
Right.
And also in breastfeeding, we do continue interferon. And you might want to look at, I see this is a question from Jemima. So Jemima, you might want to think about doing a scan at 20 weeks. And if there is a problem with placental vasculature, you might further increase the dose of heparin for this patient. Or if the patient happens to be obese, for example, again, giving a higher dose of heparin can be helpful.
Thank you. Another question is, what is the hematocrit cutoff for a polycythemia secondary to congenital heart disease?
There is no hematocrit cutoff for those patients, I would say. I try very hard not to do phlebotomy for those patients, and we don't have them on hydroxyurea either. I think they should be managed by a cardiologist, and because they need their hemoglobin to achieve oxygenation. This has been a very long bone of contention through I'm sure Professor Agarwal's career and also mine. Iron deficiency in secondary polycythemia due to congenital heart disease. The cardiologists don't like it. We're not so worried by it, but these patients need their hemoglobin to achieve oxygenation. So really it's a symptomatic thing, and it's done in close collaboration with the cardiologist. And you also have to be really careful because you probably need to do an isovolemic small volume phlebotomy if you are going to do it at all. We hardly ever do it now, and we have a large congenital cardiac unit in the hospital. Important question, though.
Right. A couple of more questions. You have a patient of polycythemia vera who has high allele burden of JAK2. Some patients develop myelofibrosis early, some don't develop myelofibrosis for a long time. So there must be additional factors besides the allele burden. And do we know those changes that occur which lead to myelofibrosis? Genetic event or?
Yes, it's multifactorial. So they've already got a high VAF, so they've probably already they've already had a problem with chromosome 9p. There is also a link with white cell count, but I think that's just a marker of a high VAF, to be honest. I think if your patient's got a high white cell count, it's almost not worth doing the VAF. But anyway, because they probably will have it. I think it probably relates to other genetic markers. You may find that the patient develops additional mutations. Often patients with post-PV myelofibrosis do have additional mutations, but not always. So acquisition of additional mutations. Inflammation is also probably important. And so if we can reduce inflammation, we may well stop drive of clonal progression. So that's where the interest in ruxolitinib as an earlier therapy may well come in, as well as suppressing the JAK2 VAF. There may also be other factors such as the microbiome, etc. You can tell that I'm giving you multiple answers because we don't know the honest truth. And there may be something, other SNPs, for example, that may be important here, which we have yet to learn. But I do think there is increasing evidence that therapy, earlier treatment, may well be important in tractioning those. And we recently published for young patients, I think I presented that data in one of your lovely seminars, that treating patients under the age of 25 with interferon was associated with less risk of myelofibrosis transformation. Not the best evidence, but still some evidence.
There are occasional patients, rare, but occasional patients who directly develop acute leukemia. They don't go through the phase of myelofibrosis. Are they different patients genetically?
We don't know the answer to that. Most patients do develop myelofibrosis first, as you quite rightly said, but some patients do go straight to leukemia. I would say outcome-wise, those patients, in my experience, tend to have a worse outcome. And treatment of blastic phase MPN remains a big unmet need. So prevention of it is the first thing. So avoiding use of alkylating drugs, and treatment, massive area of unmet need. Lots of use of azacitidine here. But so identify patients at risk and take them to transplant or whatever earlier is probably better.
Yeah, sure. Another question is, there is a case of low risk PV with a high WBC count and a high platelet count. So should I start cytoreduction?
I think there's evidence for benefit in a patient with a white count over 16 to 20. The threshold in the cyto-PV study was actually over 11. And there's published data to suggest that a white count of over 15 is associated with increased risk of vascular events. The platelet count, probably less so. So I would certainly discuss it. I wouldn't mandate it, but I would discuss it.
Right. Gopinath, you have a question that interferon availability. PEG interferon is available through Zydus. That's the only company giving it at the moment.
So there was just to say that there is a new factory that's manufacturing interferon. We went down to like one syringe in our hospital pharmacy at one point. We had a big problem. So I totally agree. It has been a challenge, but it is getting better.
Yeah. Yeah, I think that covers.
I saw a really good question, Professor Agarwal, if you don't mind me calling it out. And I think it's a really good one. It's from Dr. Vishnu Prasad. We see patients who seem more like ET with a platelet count 1,000, but hematocrit about 0.5, just above the upper limit for WHO. Would you do a bone marrow? And we worry about bleeding with the platelets during a bone marrow aspirate. I think that's a really good question. Do you mind if I address it?
Yeah, please.
So thank you so much, Dr. Prasad. JAK2 positive ET with a high hemoglobin. In my practice, I would do an EPO level for those patients, look for secondary causes we've discussed, smoking, testosterone, etc. If the EPO level is suppressed, I would treat that patient as a PV patient. I wouldn't do a bone marrow. Actually, I'm not sure we should really be telling the difference on the basis of a bone marrow. I don't know how good that test is and the interpretation is. So if my patient with ET over time develops a raised hematocrit, look for other causes, but treat as PV if the EPO is low. And then the second question about doing a bone marrow with a raised platelet count, I would definitely have the patient off aspirin to do a bone marrow in that setting. We've done an audit in the UK many years ago showing that this is a scenario for hematoma. Otherwise, I wouldn't particularly worry, but if you're really worried, why not just treat the patient and do a bone marrow after you've started treatment? If you've got a mutation, you have got a myeloproliferative disease, you could do a bone marrow then, if you need to do one. You don't need to do a bone marrow to diagnose PV though. Thank you.
Thank you. If a patient of venous thrombosis, polycythemia patient of venous thrombosis, you started on DOACs, you'll continue that for lifelong?
Well, it depends on the situation for the venous thrombosis. If it was a small below knee and if it was triggered, I might not. Otherwise, if it was a pulmonary embolus, I definitely would. Another question, would I use antiplatelet agent in combination with a DOAC? I probably wouldn't unless the patient's got another risk factor, especially in elderly patients. I think that's a significant risk for bleeding. But it is possible to combine an antiplatelet agent and a DOAC. Cool.
Yep. Any question from anybody here? No. Yeah, Divya, yes.
Hi, madam. That was a very informative talk. I have a case to discuss. A 40-year-old male who has JAK2 positive myeloproliferative neoplasm, and he had developed portal vein thrombosis. Because the portal vein thrombosis and HCV cirrhosis, HCV, hepatitis C virus, he had developed liver cirrhosis, which has caused to develop portal hypertension. For that, he had undergone splenectomy. So this is the after the splenectomy, the patient comes to us to hematology. Initially, he had JAK2 positive MPN, for which he had received hydroxyurea and 2 or 3 times underwent phlebotomy. That is the history we have. So after splenectomy, his count goes very bad. His hemoglobin and WBC are okay, but platelet goes up till 25 lakhs, and he has vascular symptoms. So 25 lakhs was too high, so we couldn't control the counts. Like starting with hydroxyurea and ruxolitinib, the counts were not in control. So he underwent thrombocytophoresis, 2 sessions of thrombocytophoresis, and brought down the platelet count to 5 lakh or 7 lakh. Later, he developed side effects to ruxolitinib because we had put him on highest dose possible. He developed spadal edema and also tried ROPEG interferon for the patient because every time his platelet count jumps around, like from 25 lakhs, it goes to 5 lakhs after giving the drugs, hydroxyurea and all. But later again, it goes back to 25 lakhs. So post splenectomy, basically the MPN counts goes very high, and only the platelet counts are much affected when compared to the WBC and hemoglobin. So in this scenario, what would be the ideal therapy that we can choose? So now his liver is okay. Only the problem is myeloproliferative neoplasm, which has gone unleashed after splenectomy.
Yes. And you mentioned the patient has hepatitis C. Is that eradicated or not?
It is eradicated, ma'am. He had received treatment for hepatitis C also.
Okay, thank you. Well, the first thing to say is, as I think you're indicating that the high platelets are the main problem here, but that's really related to splenectomy. And so you probably have to reach a point where you just can be pragmatic. There's quite a lot of pragmatism in clinical practice I've learned over many years. The evidence for keeping the platelet count below 400 is only really now emerging, but we wouldn't have been randomizing a patient like your patient in the MAGIC PV study. And we know that he's post-splenectomy, so he will have a high platelet count because of that. So the first thing is the target could perhaps be moderated. His main clinical event has been a thrombosis, and I assume he's anticoagulated. So
yes, ma'am, is anticoagulated.
Yeah. So in this setting, I think it's reasonable to allow the patient to have a higher platelet count, especially as it's difficult to control than you might otherwise normally do. So normally we'd want below 400 and maybe even lower in a patient with a portal vein thrombosis. So maybe 500 or 600 is okay if the patient's not bleeding. And then in that setting, you described use of hydroxyurea and ruxolitinib, but ruxolitinib was becoming intolerable for the patient. And actually, it's not the best agent for reducing the platelet count in my experience. If you've already got the patient on a drug like interferon or hydroxyurea, and you're really worried about platelets, you could consider adding a little bit of anagrelide. But I might also take the pragmatic route and say, look, I may do the patient more harm than good by pushing really hard to control the platelet count. So I might accept a platelet count of 600. I think it's a really difficult case. Thank you so much for bringing it.
Thank you, ma'am. Thank you.
Yeah, I don't see any other raise hand sign or questions in the chat box. So Dr. Harrison, thank you so much for sparing your Sunday morning. And once again, you have been always extremely cooperative with us. You've never refused to accept any invitation, and we have been bothering you a couple of times every year. And you have been talking to us, teaching us. You have been with us for 1.5 hours, 2 hours for each webinar. Thank you so much.
Thank you so much. And thank you to everyone who attended, but also to those who took part in the discussion. I think this is why I never say no, because there's always a very good discussion. Have a good day, everyone, and look after yourselves.
Bye-bye. And bye-bye to everybody from India and all over the globe. Thank you. Bye.